Good morning. I'm very happy to participate in this conference, this important summit, and I'm here to share with you some ideas on AI and the new medical paradigm. I hope you enjoy, and of course, at the end of this presentation, which is a taped presentation, I am available for questions in live. So I would like to talk to you about making it happen through Kiwi hospitals and organizations. And before I actually start, I would like to welcome the idea that we are building a global community for AI and medical innovation. And definitely this means that AI is promising and it promises to change healthcare, but care with AI is nonetheless problematic. Carefulness is key, and carelessness can be legally a problem and costly. So in this presentation, I will explore some implications of AI in medicine, particularly looking at public implications, as well as changes in the medical paradigm. And I want to advance an idea, which is not a very sophisticated idea, but it brings together a lot of very important concepts, in my opinion, which is the Kiwi organization, Kiwi hospitals, or healthcare organizations, which has to do with aspects that have often been neglected as we embark on this AI adventure: knowledge, interoperability, and wisdom. So first, let me just tell you where I'm coming from. I'm coming from a small country, Portugal, which, however, has made its name in e-health. And the reason Portugal has made its name in e-health is to do with a significant investment and strategy in the development of national-wide digital health services. Of course, I don't have the time, nor is this the opportunity to tell you about that. So I welcome you to visit my website, where you will find an article that I've just written and published that details you the history of these developments. Why are they important? Because they highlight the importance of having a strategy. And I think for AI, we also need a strategy. National strategies for AI is very different from national strategies from healthcare and how to use AI in healthcare, which I advise all countries should have. And we did build some of that in our own country at some point in time. But today I want to talk and focus on new paradigms, new vision, new patients, professionals, and organizations as we embark on AI and robotics to change medical paradigms. This, of course, will mean new digital health leaderships, and it will also mean that possibly we need to change our organizations. For example, building national digital health strategies and also organizations that can fulfill those strategies are important aspects. The last two ones, unfortunately, I don't have the time to cover, but I'm available to questions on those or to interact later on by email. So let me first share my vision, my opinion on what are new healthcare systems in the future. They are digital, of course, but that means what? It means that they need to be preventive, paperless, they need to be empowering, personalized, and accountable. And in a way, they need to make sure everyone can become an healthcare creator. And this is key. The concept that people alone can care for themselves is, I think, fundamental as we see more and more sustainability issues on health services. And also we see people want to take in their hands the care of themselves and sometimes of their own relatives. So these four trends, if you see, they are actually already happening. Changes in processes, professionals, and patients, but also we need to change the care philosophy for more interpersonal collaboration and health-aware citizens. And today's crisis, today's pandemic, shows how important health-aware citizens are. Rethinking any need for physical interaction. This was important before COVID. This is even more important right now. Telehealth is the new health. And we also know that data security, privacy issues, and interoperability are key components to gain the respect and the trust as we step into robotic care and robotic professionals. People will be more afraid if they don't know what's happening to their data and how these data is used by these robots. So we need to be transparent on that. And of course, the rethinking of healthcare systems was already happening, but after 2020, definitely this year has gave us an extra push and an extra motivation. Digital patients is a symbol, is a double-sided concept. So on one hand, patients carry digital with them more and more. Every day you see patients having more and more gadgets, more and more devices attached to their body. And this is a good thing because it helps prevent disease, it helps cure disease. But also we see more and more digital sickness, patients getting sick from too much digital exposure. So we can tackle this, but if we accept this concept and we explore this thing. And one way to explore this concept of digital patients is to think of health as an index, as something that fluctuates around the day and around the lifetime. So you're never healthy, you're never completely sick. There's always bits of you that are healthy, bits of you that are sick. That's the homeostatic concept of health. And this is important because even throughout your lifetime, there are moments where you feel better and there's moments where you don't feel so good. But even before birth, the fetus may have diseases that we need to take care for and document and register. Whereas after death, organs, if you have donated organs, if organs have been taken away from your body, they carry with them diseases and cells that may bury in their genes and in their molecules, proteins and others, significant impactful diseases that will be passed on to the body that receives that organ. So the concept of health as something that you can manage is important also if it is possible to measure. There's a very old saying that says that you cannot manage what you cannot measure. So if we want to have digital powered patients, patients that are capable, they feel empowered to take care of themselves, then they have to have this proxy. This data is perhaps gathered with AI. It's possibly the only way to obtain an index of your own health is by having this data processed. Now let's imagine a simple analysis of crossing two realities, the healthcare index, so how healthy are you, and the digital exposure. And you can immediately see that there are people that are excluded from digital. They don't know how to use digital, or they cannot afford or cannot have access to digital. They are to some extent not so healthy. They don't have access to telehealth, they don't have access to certain digital tools and digital literacy tools. As you progress and you start using digital tools more and more throughout your day, your health actually gets better. This is where you would find all sorts of health apps and wellness apps that can help you get better in your life. But after you cross this point, which of course depends on each person, you can get sick. You can start to get sick. This I call digital overweight or obesity. It's too much digital is not good for your health. It may harm your vision, your tendinitis, irritation, information overload, even burnout syndromes. And of course, if it goes to the extreme, that your health becomes negative, you're actually suffering significantly. You will have dependency syndromes, for example, or personality dysmorphia syndromes. So this has to do with living a sort of a second life. In the digital world, you see these problems associated with social networks, for example, and there's a lot of research in teenagers. And then finally, there are even accidents because people keep looking at their phone while driving or even if they don't die physically, there is sort of social rupture and isolation, sort of alienation, sort of societal death. And there's evidence to support these ideas. There's a lot of research looking at the implications of digital in health as a negative thing, as there are, of course, also in a positive way. So you can think of how technology is getting into people's body, brain, and mind. So if you actually cross the body personhood intrusiveness axis with connectivity to digital, of course, there are again the digital excluded citizens. And it's important to remember that even in some countries, even in Europe, we have 15–20% of people that do not access the internet. Of course, this depends a lot on the countries, and it varies with social economic status. But again, let's go back and we see that if people use portals or apps, we are still at the sort of a low level of connectivity. We're talking about personal outside the body interactions. But when you talk about devices and implantables, like pacemakers, insulin pumps, drug pain killer infusion pumps, and things like that, then we are starting about technology that becomes personal inside your body. And there's already research on micro robots capable of going into an artery or a vein to take away the atheroma plaque, so that you do not have a stroke or you don't have a heart attack. And finally, there are researchers looking at this concept of cognitive nanobots. These would be robots that would be scavenging your brain and removing proteins like tau protein and other proteins that are responsible for dementia. So they are basically inside your brain taking care of your mind. And they will, to some extent, change the way your mind works because they are impacting on that. And for those of you that are interested in research in the areas of artificial life, you will soon to find that there's very interesting work being done on posthumanists and avatars. So when our personality is somehow transferred to a cybernetic life, which makes us think that it's not just about hardware and software. I've long used the word peopleware as well. This was actually coined by Nancy Lorenzi in the United States. I like it very much, this concept of how people use the software. And then I use the word userware to refer to citizens, patients, as we use the IT on them to take care of them or prevent their diseases. And then finally, this concept of mindware. So a sort of software that could change your mental processes. And it's important to keep in mind that you need to have these ideas if you want to avoid them or if you want to pursue them. Whatever choice you make, you need concepts. And digital health is not just about doctors, hospitals, or information systems, robots, or nanotechnology. It's about citizens. It's about us. How do we use technology? How do we get healthy or not so healthy because of digital tools? Now let's look at professionals. And the new professionals are needed, as well as what I call Kiwi organizations. Kiwi organizations are those that are knowledgeable, intelligent, wise, and interoperable. I have finished the paper on the Kiwi hospital concept. I have it in English, in Japanese, in Mandarin, in Cantonese, and in Portuguese, of course. I'm from Portugal. So if any one of these languages is of interest to you, you can read it in any of them. Anyway, very briefly, hospitals are, like any healthcare organization, quite knowledge-intensive organizations. But to be a knowledgeable hospital, it is to process that knowledge in an informatics way. To have, for example, operations that are triggered by clinical decision support systems that use AI to guide decisions of doctors and nurses. It is to be intelligent, and intelligent as an organization means, of course, the usage of artificial intelligence as it steps into medicine every day, more and more. but also it's about intelligent hospital management and using AI to manage healthcare. And then WISE, it's fundamental. Wisdom to know how to use the technologies. Wisdom to discuss how these technologies should benefit humankind. So this is digital ethics. Of course, having a clear data governance and cybersecurity on your data is a wise decision, because you want people to trust you and they need to know what you're going to do with their data. You want people to trust you. You want to make sure you keep their data safe on your hands. And then finally, interoperability. And interoperability is not just about connecting software. It's not just about HL7. HL7 is very important, of course. Technical interoperability uses standards like HL7 standards, but it's also about how people interact with each other, how interoperable how are our processes in hospitals and other organizations. Digital professionals are therefore Kiwi thinkers. They need to be knowledgeable, intelligent, wise, and interoperable. They need also to embrace full healthcare digitalization. I think they need to be on the driving seat for digital therapeutics usage, participating in startups and small, medium-sized enterprises, define ethical and medical technical AI development paths by active engagement and participation, not by stepping back and saying, we will not use AI tools. No, there's only going to be two types of doctors, those that use AI tools and those that have been excluded by those that use AI tools in the future. So redesign their professional associations. And finally, the future professionals are likely to be bionic professionals. So I foresee surgeons, staff nurses, physiotherapists as some of the first bionic professionals, because robotic arms will give you more precision, more strength, and more repetition, which are important for all of these professionals. Now, how does the system as a whole connect digital professionals, digital patients, and data? Well, you need an intelligent national health system. And to move from big data to smart data is to do the digital transformation and really get a data-driven healthcare system. And of course, then focus on precision medicine as population health approach, and primary health care as precision prevention. So primary care is not just about seeing the patient when he comes to you, it's actually about preventing it in a precise way for that patient, for that family. If you think about vaccines today, everyone gets the same dosage. Have you ever thought about that? How strange that is. In all other medicines, dosage changes with age, with disease type, sometimes even with body functions like kidney disease or liver disease. Whereas on vaccination, you just give the same dosage to everyone. How unprecise this is. It's good to start thinking about these things. And one of the ways to work with data is to have core values. It is fundamental to work on values, because data is about the people that give you that data about themselves. So you want to trust, and you want them to trust you. You want to have high quality data. So this has to do with the validity of data and indicators that you build, but also with having multiple data sources. That's the best way to ensure you have good data, is to have more than one source for that data. So you can cross-reference, you can double check. Efficiency, have interoperability and integrated systems, and innovation. Innovation is key to doing some of these things, like data collection, in a way that is not so troublesome for professionals. And this brings us to a new medical paradigm. I would always like to think that, of course, the new concept of personalized medicine is explicit personalized medicine or implicit. Explicit is when you sort of know that you are going to use multiple sources of data, like genomics, proteomics, to tailor, for example, a specific drug to a specific patient because of his genetics, of his phenotype. But implicit personalized medicine is to do this by using AI tools, which are to some extent a black box. You don't really understand or know exactly how the AI system found out a certain probability, advises a certain course of outcome and course of action. And then you can think that these are then questions that significantly alter the medical paradigm that we have lived. And if you think about medical paradigms over the years, I would suggest, this is of course a personal classification, that you would have a sort of a mystical paradigm. In the old days when people felt sick and they went to the tribe chief and they asked for help, and there was maybe a wizard, a magician that would take care of them. In traditional medicine with Hippocrates, somehow more structured, but still quite mystical at some times in some respects. And then scientific medicine, evidence-based, clinical trial-based medicine, and then personalized medicine, explicit and implicit. And when you actually plot, and this is what I think, this slide always makes me very excited. This is when you actually plot health data and computing power against time, of course it goes up exponentially. And then you have mystic traditional paradigm until the 19th century. It's about the human experience. It's about the feelings of the patient. It's about empathy. It's about engaged human doctor-patient relationship was born here. The magician, the human physician, the doctor, they sort of are one concept to some extent. And then you start entering into a scientific era where you have papers, you have guidelines, general drug indications, and you create disorders, classes of patients. You classify them. You start saying this patient has diabetes type 1, diabetes type 2. You have doctors. That they study these guidelines, they study science, they apply the science, somehow in a sort of non-personalized way. And because of that, we start having at the end of the 20th century, beginning of the 21st century, we start having a discourse of personalized medicine. This is sort of a reaction to the generic way of treating people, because we would treat groups of people. Now people want to be treated individually, specifically. And pharma companies also want to do and design precise drugs for precise diseases or for precise patients with specific manifestations of that disease. And this means having a lot of data and using algorithms to analyze that data. This does not mean necessarily you're using AI. It means you're using complex algorithms that are mathematical, but they are still explainable. They're explicit. But of course, we are now entering self-care and drugs guided by AI analytics. In here, we are talking about implicit black box medicine. And here, doctors are no longer just digital doctors that needed to use an electronic health record in order to compute all the variables and provide personalized medicine. In the future, implicit personalized care means what I call robo-doctors. Doctors that work side by side with the AI software. And they are making decisions based on that. This links to intelligent public health. Today's public health is a topic. We talk about public health in many, many conferences. I'm not going to talk about public health for COVID today, but we know we need early warning systems to outbreak detection that are much more intelligent than the ones we had on the current outbreak that we are all suffering from. Now, what are the legal implications of AI? Well, this is a complex topic, and I'm not going to go into it in too much detail. Just to make you think, for example, the GDPR, the European General Regulation for Data and Privacy, It applies across the world as long as it's a European citizen. So it implies everyone, but it's not just because of that that it is relevant. It is a framework to think about data protection. And for example, the principle of data minimization, which is a simple principle, you should request, store, process the minimum data that is necessary, adequate, relevant, and limited. It says, well, questions for AI, how before an AI has been used and processed data of many subjects, how do we know what data can be ignored or not used for the model? Before you do the model, how can you ignore certain parts of the data? And thereby you would follow the data minimization process. So how can you follow this principle without having run the algorithm for the first time? However, a more interesting question is, can AI algorithms be designed and integrated in online AI-based healthcare services in such a way that as soon as a variable is found to be irrelevant for the predictions, the system, for example, online service, stops to ask for that information from the users? I have created my own blog on my website on these topics of legal implications for AI. So you can go and have a read of these topics, and you can drop your own comments and answers to these questions. So questions also about the right to human intervention on AI systems. Is there a right to human intervention, and how do you do that? How do you actually create this right and make it real? How do you stop the algorithm in the middle and ask him to explain how it was working? And finally, another type of questions, for example, on explainable AI, explainable artificial intelligence methodologies, can make provisions that need to be clear, and doubts about which healthcare settings and patients' characteristics create conditions for open, comprehensive, and frequent settings. So explainable AI is a sort of method, a sort of technology, a sort of way, and I'm doing this on purpose to talk about explainable AI in these lay terms, because it is a way, perhaps, to bring the patient into the equation and allow him to consent, but more than consent, we want patients to participate in AI development and usage. This, I want to be my final message, because this means having true Kiwi healthcare organizations that are, I repeat, are knowledgeable, intelligent, wise, and interoperable. And if you are able to read this slide, it's because you are interoperable in Mandarin. Thank you very much for your time, and I am very happy to answer any questions right now or online over my email. Thank you so much.
Okay, thank you, Dr. Dr. Martins. Nice talk, and it's very insightful. Yeah, thank you. The talk covers about the AI age, the liabilities, and the AI digital professionals. How do we embrace the AI times new issues or deal with the challenges? So it's great. Actually, I would like to hear more about the insights. Now we open the questions to the audience. Please ask questions at this time.
Okay, I don't hear any questions, so maybe I can ask one question to Henrique. Hello, Henrique. After a long time in government, now you're back to operations, and I wonder to what extent you're actually implementing these Kiwi principles in the hospital that you are a CIMI of.
So one of the challenges right now, as you may, of course, understand in hospitals, is to survive, well, at least in Europe, is to survive the workload regarding COVID. So there's a very short attention span to innovation. But at the same time, there's a big interest in telehealth. And I think, well, at least what I am doing right now is working with a lot of players in telehealth in Portugal and also in Spain. We have created a working group to bridge experiences from Catalonia, Extremadura, and all of Portugal. Actually, we just finished the report yesterday. I think it's online. And basically, we need to boost the usage of digital. I think right now AI is also something people are starting to look more in hospitals in Portugal, definitely for imaging, and I think that those are the principles. The other area that we need to work, that I'm trying to work at the hospital level, is making sure ethics commissions move from biomedical ethics and sort of clinical studies approval to a broader thinking of ethics to include digital topics, as people have a lot of questions, and sometimes the questions, not necessarily the answers, stop people from progressing. So you need to have somewhere where the answers are at least partially addressed and even temporarily provided to people.
And one more question. In the previous days, we talked a lot with nurses in Europe and in China. We had a session this year is the year of the nurses. We talked also with emergency physicians a lot. And one of the things that I would like to ask you in that regard is how ready are the new medical students? You are a teacher as well. In a medical university, teaching them management. Are they ready to manage the new challenges of COVID?
Yeah, I think that's a very good question. Well, I had to jump a few slides that I have on another presentation on medical education and AI, to say that medical schools and nursing schools need to radically change for two reasons. First, they need to prepare professionals to work side by side AI tools. I'm now finishing my own master's dissertation on AI liability, and I'm using the case of nurses in triage. So when nurses in hospitals use AI-based triage softwares, and to look at this. So this is a law analysis. But anyway, the point being that definitely schools need to train these professionals. Here I've worked with 2 medical schools. And the funny thing it was the medical students that invited me to organize a webinar on AI and innovation. So the medical students from the early years, they are quite alert to the need to learn, but they feel and struggle that medical schools, and I think the same happens with nursing schools, although I think nursing schools are more progressive, more innovative oftentimes, I have found over my life, but still it's often the students that demand this new training, which is quite good, because that will mean that once initial reaction by old-timer professors moves on, we will have that change happening in health education.
Yeah, actually, Dr. Martins, you talk about since the computing power is boosting the medicine trend. Previously, in the early time, we have the mystic or traditional medicine, and it generally becomes scientific. I think we are at the scientific age, the medicine age, in your category, or already entered the personalized medicine era. What do you classify what we are in now?
I think if you go down today to hospitals, they are somewhere between the mystical and the scientific.
Oh, I see.
you still
early
see,
stage.
yeah, I really think you still see, especially in surgery, you still see some people trusting their surgeon as if he was some kind of semi-god. They often don't even ask for an explanation. They will just open their bodies to them. More and more, of course, people are demanding to be explained and told the outcomes or the expected outcomes of surgery. But still, you have a few mysticals. The funny thing about this concept is that, of course, when you talk with pharma companies and with pharma company doctors, they would like to think we are in personalized medicine era, and they talk about that. And then when you go to the IT universities and the engineering schools in China, in Singapore, in Japan, and in Portugal, they think we're already all using AI. So it's interesting. So I think there's for all sorts. But the more interesting thing about that slide is that if it was a 3D slide, the corners would connect. Because when you get to the point that your robo-doctor makes decisions for you and he's not even explainable, they can't be explained, you're actually back to the mystical era. You're actually back to the point where you started, because you have to believe in him. You have to trust without the capacity to scientifically inquire why he's suggesting this. And that I find very, very fascinating.
Yeah, I would say it's a kind of course shape, right? Course shape.
Yes,
We join
yes.
in the middle and has the development on the top. Okay, thank you very much.
Thank you all.
It's great talk.
Thank you for your questions as well. And let's have a nice morning. Thank you, or afternoon over there in China. Thank you.
Okay, yeah.